Hello, everyone. Good morning and welcome to our session on COVID-19 and air quality. I know many of you probably have got a little tired about COVID-19, but trust me, we have some very interesting speakers today. So without further ado, I'll just turn to our first speaker, Dr. Randall Martin. He's a HAQAST member and he's at Washington University. So Randall, the stage is yours.
Like many of you, I still find it really quite remarkable to remember a couple of years ago when we were suddenly forced into this lockdown environment and our lives really changed really quite suddenly. The transportation plummeted and the media showered us with these beautiful clear sky images that implied an improvement in visibility and therefore implied a reduction in PM2.5, which is the primary determinant of visibility. Now, at the same time, we received some conflicting information about increases in PM2.5 in regions or near regions of strict lockdowns in North China. So we wanted to investigate more comprehensively the effects of the lockdowns on air quality and focused on two species, NO2 and PM2.5, that are readily observed from satellite. And to do so as part of our overall HAQAST objective, which is to improve satellite-based air quality estimates for the community. And as part of this activity, we'll also bring in information from the GeosChem chemical transport model that's both of value to relate the columnar observations to ground level quantities, as well as to assess and understand the observations. So we'll begin first in the space of NO2 because NO2 is most directly related to the transportation emissions, and begin with tropospheric NO2 columns from both OMI and TROPOMI, and apply the GeosChem model to calculate the coincident local relationship between those observations and ground level NO2 concentrations, augmented by additional information from the satellite observations themselves about the spatial heterogeneity in NO2 that therefore informs the shape of the vertical profile, in essence, informs the shape of the relationship between the column and the surface. And this yields the resultant surface NO2 concentrations that we heard about from Tracy yesterday, that introduced this paper that came out this week, a new monthly surface NO2 data set that is publicly available and exhibits a pronounced degree of heterogeneity, especially contrasting between source regions and non-source regions. And then we wanted to apply that data set to examine the changes that occurred during lockdowns. And so we'll focus on the months of strictest lockdowns. That was April throughout most of the world, February in China, and compare the satellite-derived concentrations during that month in 2020 with the prior year, and on the leftmost column, and then compare it with the long-term trends that were inferred from OMI and TROPOMI. And what we found was that throughout the world, at urban areas throughout the world, that there were pronounced reductions, that those reductions were on the order of 20 to 40%, remarkably larger than the long-term trends that were inferred from emissions controls, roughly 15 times larger in a population-weighted sense at the global scale. So this is a remarkable change in the surface NO2 concentrations. Now we'll continue the story for PM2.5, and in that case, then turn to a suite of satellite observations of aerosol optical depth that are constrained by their relative errors with respect to the ground-based AeroNet network, allowing for inversely weighting these different data sets by their relative errors to produce an overall composite estimate of aerosol optical depth from satellite observations. Then we'll coincidentally sample that composite with the GeosChem model to calculate the local coincident relationship of AOD to PM2.5 to produce a geophysical satellite-based estimate of PM2.5 that we subsequently statistically fuse with ground-based observations to produce a hybrid estimate. and began our investigations in China, where and when lockdowns were most strict here in February. And on the leftmost column, the filled circles show the PM2.5 concentrations that were from the measurements themselves. The background shows the satellite-derived estimates for 2018, 19, and 20. And overall, high degree of consistency between the in situ and the satellite-derived values to within a few micrograms per cubic meter. And a clear reduction that is apparent in Southeast China of 10 to 20 micrograms per cubic meter. But if we look at difference maps on the right, it becomes apparent that not only was there this decrease in Southeast China, but there were increases of comparable magnitude elsewhere, notably in North and Northwest China. We continue the story on with Europe. Again, the leftmost column shows the data for 2018 through 2020. Again, a high degree of consistency between the in situ and the satellite-derived values to within 1 to 2 micrograms per cubic meter. No clear anomaly in 2020 in Europe. When we look on the rightmost column showing differences across years, the differences depend primarily on the choice of reference year. Now, upon further inspection, it does appear that there was a consistent change that occurred in 2020 with respect to both prior years in Northern and Eastern Europe. We'll continue the story on with North America, again, focusing on April, again, for the period 2018 through 2020. Again, consistency between the satellite-derived and the in situ values. However, no clear anomaly in 2020. Differences on the right show that the differences are primarily driven by the choice of reference year. So it does appear that there was some cherry picking going on in the media where there was identification of clear sky days that would likely have occurred in the absence of the COVID-19 lockdowns. And we can understand this by turning to the GeosChem model to examine the effects of meteorology, holding emissions fixed across 2019 and 2020, and examining changes due to meteorology alone. And in the leftmost column, we see that changes due to meteorological variation can explain most of the features that we saw earlier, can explain decreases of 10 to 20 micrograms per cubic meter in Southeast China, increases of comparable magnitude across North and Northwest China, decreases across Eastern and Northeastern Europe, and relatively little change across North America. We find in the model that most of these changes are driven by changes in mineral dust, source strength, and advection patterns that are compounded by changes in precipitation and mixed layer depth that lead to feedbacks across the secondary inorganic and organic aerosol systems. Now, we can go ahead and examine the sensitivity of PM2.5 to transportation emissions, and here impose a 50% reduction in transportation emissions. We didn't really know the degree of that change. And what we find is that the change in PM2.5 due to this decrease in transportation emissions does lead to features that contribute to the changes that were found in the observations. It further decreases PM2.5 in southeastern China, as well as parts of Eastern Europe. So contributes to consistency with the observations, but it's a relatively small change compared to the change due to meteorology. And at first that may be somewhat surprising, but is nonetheless reinforces prior expectations about the complexity of sources that contribute to PM2.5. So here I'm showing you a sensitivity simulation led by Aaron McDuffie that examined the relationship of PM2.5 to different sectoral sources. And what we find is a complexity of sources that contribute to this PM2.5 burden, that residential combustion is the largest source, but overall that these sources are oftentimes of similar magnitude. Transportation is an important component of this suite of sources, 6 to 7% of population weighted PM2.5 at the global scale, At the regional scale over northern mid-latitudes, it's 8 to 15%, still somewhat larger, but nonetheless a relatively modest contribution to the overall PM2.5 burden. A factor of 2 reduction in this modest source is unlikely to lead to clear signals in the overall PM2.5 distribution. As part of this effort, or subsequent to this effort, we've released a new monthly PM2.5 data set to the community, spanning the period 1998 through 2020. And here I'm showing you an example of this data set showing pronounced seasonal variation and trends by season that show reductions in PM2.5 in East China that began earlier in summer than they do in winter, likely related to how emission controls were phased in with a focus initially on sulfate before focusing on some of the other sources of PM2.5. So with that, I'd like to throw up my conclusions, remind you of our new publicly available data sets for PM2.5 and NO2, and thank you for your attention.
Thank you, Randall. So now let's move on to our next speaker. If you have questions, please put it in the chat box or Q&A. We're going to answer all the questions at the end of the presentations. So our next speaker is Dr. Gaige Kerr, and he's from George Washington University, and he's an investigator on Susan Annenberg's team and also part of our HAQAST family. Please.
Thank you, and hopefully everyone can see this slide. I'm going to be talking about NO2 pollution as well, and the way that we can leverage the pandemic, this really unique natural experiment, to understand what's driving NO2 pollution in cities and the populations that it impacts. Before I move on, a couple quick things. The first is that you see a bunch of folks and names pictured on the bottom of the screen. These are people that have been really instrumental in the couple of projects that I'll be detailing today, so thank you to all of them. And then the second thing is I'm going to keep things intentionally pretty high level and broad today. So if anyone wants to talk more about some of the methods and data that we use in these studies, I'm happy to do that in the Q&A. But I wanted to motivate my talk by sharing some plots that were produced by my colleague Dan Goldberg, showing what a strange year 2020 was. Strange for a number of reasons, obviously, but in the context of this talk, it was pretty strange for NO2. If you take a look at the light blue time series in these 4 cities, you'll notice that that blue time series, which corresponds to 2020, was pretty low, particularly in March, April, and May. And I should mention too that these data that Dan produced were using the new version 2 of TROPOMI data. So we want to build on some of these results and again, think about what's causing these changes in NO2 as well as the populations that NO2 impacts. So the questions I'll be addressing today is whether changes in NO2 during the pandemic were equitably and justly distributed among different demographic groups in the US, what changes in NO2 during the pandemic can suggest about the source of NO2 and ethno-racial disparities, and finally, how we can use this natural experiment to inform long-term policy and protect public health. The first project I'll be talking about today is titled COVID-19 Reveals Persistent Disparities in NO2 Pollution, and the study was published last summer in PNAS. In this study, we used TROPOMI NO2 retrievals and averaged them to underlying census tracts to show that the pandemic reduced but didn't eliminate NO2 disparities. You can see that result clearly if you look at the length of the dashed bars for each of these different cities or regions and contrast it with the length of the solid bar. The dash bar here corresponds to NO2 disparities for different racial subgroups during the 2020 lockdowns, and the solid connector bar corresponds to NO2 disparities back in 2019. And you'll notice again that these dash bars are shorter than the solid bars, which means that the pandemic reduced the NO2 disparities. That's a good finding, especially considering what we know about NO2 disparities and environmental justice. But the more alarming finding that's embedded in these results is that during the pandemic, during this unprecedented global economic downturn, the least white communities in the US still continue to face higher levels of NO2 than the most white communities faced prior to the pandemic. We dug a little bit deeper into these results to think about what's causing these ethno-racial NO2 disparities. And the plots that you see pictured here were one of those avenues of inquiry that we went down to investigate where different NOx sources are in the urban environment compared with our demographic variables. We took a look at roadways, ports, industries, airports, and railroads. And if you're looking at any one of these plots towards the plot's left-hand side, what you're looking at is the density of that particular NOx source in neighborhoods and census tracts that tend to have lower income and educational attainment and tend to have a higher proportion of racial and ethnic minorities. So now that that explanation is out of the way, what we notice in these 5 plots is that it's really only roadways and railroads that are disproportionately located in marginalized and minoritized neighborhoods, at least on a national basis. Of course, there are communities in the US that suffer from EJ issues related to, let's say, airports or ports. But again, on a national basis, roadways and railroads really stand out as being disproportionately cited in marginalized areas. Now, for the sake of time, I'm not going to summarize all of the analysis we did related to this study, but we also looked at how these different NOx sources contribute to the total urban NOx emissions, as well as trends in these different sources throughout the pandemic. And together, these analyses really clued us into the impact that heavy-duty diesel trucking has on NO2 disparities. So overall, what we showed in this study is that marginalized and minoritized communities experienced temporary improvements in NO2 pollution during the pandemic, yet these communities continue to face higher NO2 levels than communities that have a higher proportion of white and non-Hispanic residents. By looking at the locations of NOx emitting activities, as well as their trends in the pandemic period, we showed that there's an equity that's really built into our urban environment, particularly when it comes to the placement of highways, interstates, and other busy roadways. And the heavy-duty diesel trucking that takes place on these roadways presents a really important source of NOx and NO2 inequity, given the fact that it uses these roadways that are preferentially located in marginalized and minoritized areas. In the second part of this talk, we're going to shift our focus from talking about EJ issues in the US to talking about NO2 pollution in a cohort of European cities. And specifically, we're going to investigate how diesel passenger vehicles influence changes in NO2 during the pandemic in these cities. You can imagine if we're looking at changes in NO2 across a number of cities in Europe, those changes in NO2 during the pandemic are going to be complicated by the fact that these different cities experience different meteorology and other confounding influences, kind of like what Randall mentioned in his talk. So in order to account for these moderating and confounding influences, we joined together model output from a NASA atmospheric composition model with observations within a machine learning framework. To illustrate that framework, I've included a time series here of modeled and observed NO2 averaged over the city of London. Let's start out by looking at the dashed gray time series, which corresponds to our raw model output from this NASA atmospheric composition model. Now, if you compare this gray time series to the solid black time series, which is our observations in London, you'll notice that there's this offset, this bias between the two. So we use this XGBoost machine learning framework to correct this bias. And we correct this bias as a function of some of those confounding influences that I mentioned earlier, like meteorology, as well as traffic patterns. And in doing so, we arrive at the dashed black time series, which I've labeled here business as usual. Now, the reason that this time series represents a business as usual scenario is because our model, which we bias correct to observations, doesn't have any information in its emissions inventory about the pandemic and the ensuing changes in emissions. So you'll notice during 2019, when life was quote unquote normal, the business as usual and observed time series fall basically on top of each other, which means that our bias correction is doing a good job at understanding what's driving that bias between model and observation. But as we go into 2020, into February and March, and the world begins to turn upside down, these two time series begin to diverge. And by the time the United Kingdom has declared a lockdown period in mid-March, these two time series are consistently offset from each other by maybe 5 to 10 parts per billion. So it's this difference between this observed and business as usual time series that we're calculating for each of our European cities. And as I go into this next slide, I'm going to refer to this difference as delta NO2. So if we take a look at delta NO2 and compare it to each city's fraction of diesel-powered passenger vehicles, what we see is that there's this strong, significant relationship between these two quantities. As each city's fraction of diesel-powered passenger vehicles increases, so does the NO2 reductions during the pandemic. There's a couple different ways that we can slice and dice these results. We can look at the NO2 reductions in cities with the largest versus smallest diesel shares. And that analysis reveals that cities that have the largest diesel shares have about a 3 times larger NO2 reduction than cities with the smallest shares. If we look at the slope of the linear regression fit among these data, this slope provides us with a pretty succinct result, or succinct summary rather of our results. And this slope indicates that for every 10% increase in diesel shares, sorry about that, there's about a 6 or 5% decrease in NO2 during the pandemic. So what we showed in this study is that reductions in NO2 across this cohort of European cities were substantial, and they had a pretty substantial range as well. But specifically, cities that had the largest share of diesel passenger vehicles experienced the largest NO2 reductions. And perhaps this isn't the most surprising finding given what we've known for years, for decades about diesel fuel. But this study does provide another drop in the bucket to highlight the dirty reality of diesel fuel, as well as shows us ways that we can leverage models, data, and observations in a machine learning framework to understand results on kind of a rapid basis without the need to spin up really computationally intense models. So to return to the questions I opened our talk with, the first question asked whether changes in NO2 during the pandemic were evenly distributed among different demographic subgroups. And the answer to that question is no. The largest NO2 reductions occurred in minoritized and marginalized communities, yet these communities continue to experience pretty alarmingly high levels of NO2. By taking a look at what's driving these changes in NO2 during the pandemic, we showed that it's really diesel fuel in a couple different forms that's driving some of these NO2 changes and disparities. In the US, heavy-duty diesel trucking was linked to NO2 disparities, and in Europe, we showed how diesel passenger vehicles impact cities' NO2 pollution. Finally, looking ahead, our results suggest that electrifying light and heavy-duty diesel vehicles will not only reduce NO2 pollution broadly for everyone in the urban environment, but might have outsized benefits as well for marginalized and minoritized communities. So that's what I have for us today. I'm looking forward to the Q&A discussion, and thank you all for the attention.
Thank you, Gaige. So now our next speaker is Adeline Yerkes from the National Association of Chronic Disease Directors. Adeline, you have the stage now.
Adeline, well, we can't hear you if you're speaking.
We can see your slides.
Good morning, and thank you for your invitation to share the use of satellite data in skin cancer prevention. I am a consultant with the National Association of Chronic Disease Directors, and I want to set the stage for the use of data by first introducing you to our association, which will give you a better understanding of what we utilize the data for. The National Association of Chronic Disease Directors is a nonprofit, member-driven professional association with 7,000 members who are employed in chronic disease prevention and control arena in public health in state, local, territorial, or tribal health departments. Each chronic disease director is an equal voting member. The association of over 30 years was developed with our consistent vision to advocate, educate, and provide technical assistance to our membership to develop our knowledge, our leadership, and our public health capacity to address the multiple issues that you see over here on your slide, like Alzheimer's and healthy aging, or healthy communities, cancer prevention and control, which this project relates to. We also have coordinating centers which advance the practice of chronic disease public health practice. And so there's a coordinating center for epidemiology and environment, or in epidemiology and evaluation. There's a coordinating center for professional practice. We also have projects around various different areas, such as the public project in the Pacific Islands. And this is somewhat related to why we chose this skin cancer project and the use of a dashboard in our association with Emory University. The association was developed over 30 years ago. And with our consistent vision, we advocate, educate, and provide technical assistance to our membership. Now, our members that vote are from the state, the tribes, the territories, and the staff that are within the state are eligible members and serve on coalitions, work groups, councils, that type of thing. So they're eligible to work on these groups. Only the chronic disease director has a vote on how things are going to go. The associate members are our partners that we work with, and that's frequently the federal employees that like at CDC or NIH, and with this group, NASA, and or the voluntary agencies such as the American Cancer Society is also one of our closer partner associate members. Our organization uses a consultant model, and this is a model that is very flexible to funding needs, garners subject matter experts in the various areas of chronic disease prevention and control. The consultants work from their own residence, so therefore we are very geographically dispersed and have a great knowledge of what is going on locally. And for example, one consultant lives in the Pacific Islands, and so she understands their culture, can speak their language, and so is a great asset as we develop programs for the Pacific Islands. As consultants, we're recruited for our ability to develop collaborative relationships, and we generally have more than one area of expertise. For myself, I was a previous chronic disease director in the state of Oklahoma. But my true love over my complete career and practice has been in women's health. And so everything that I think about in the projects that I'm involved in have a women's health lens. We are able to drive collaboration when we're interviewed. Frequently, we are interviewed for our collaborative skills and who we know in our own communities and who we know on a national level. Now, we get the work of the association done through various groups. Our projects are developed from work groups, and usually they are the disease-focused council who conducts a focus group or a work group. And the members then working in that area, such as the Cancer Council, assess their membership and what their membership needs are. They'll usually do a gap analysis, a learning needs analysis, and then come to us with their results. From those results, we develop a concept paper, and this concept paper is then sent and presented to our funders. This addresses the needs of our consumer, who are the members of the chronic disease prevention and control staff who work in states, tribes, and the territories. Hence our project, which is a skin cancer prevention materials program to increase the capacity of comprehensive community-wide skin cancer prevention programs in states, tribes, and territories. We have a number of partners on this project. We partner with the Comprehensive Cancer Coalition from the various states through this Cancer Council. We collaborate with the CDC Cancer Prevention and Control Skin Cancer Work Group, the National Skin Cancer Prevention Foundation, the CDC Environmental Tracking Network, who is our major guru in developing easy, usable dashboards, and then Emory University. The dashboard uses the data from the Rollins School of Public Health, and it's the ozone monitoring instrument level 2 surface irradiation product that is aboard the NASA satellite that we collect the data from. And the purpose of this project was to develop new innovative materials to support those people working in the community as they address skin cancer prevention and control. Now, the dashboard is very nimble. It's very easy to use. As you can see, you can select your own state, and there are a number of different variables that can be also looked at on this map and dashboard. The dashboard is patterned after the heat and climate dashboards that were developed from by CDC Environmental Tracking Group. When this dashboard was developed, the interviews were done with state cancer epidemiologists and cancer control directors who were available, and they shared with us what they needed from a dashboard and how they better needed to express daily UV radiation in their own communities. The state members stated that the coalition members, once this dashboard was developed, could easily utilize this dashboard. They were able to produce their own fact sheets and the educational materials that needed to come from the dashboard. Now, the dashboard was essentially developed from what we got from the membership, as you heard. And then it was beta tested by the epidemiology and evaluation group from the Cancer Council. And then there was also a little bit of private beta testing because I had my 3 teenage grandchildren tested also. The dashboard has 7 different variables for your use, not just the UV radiation. We can look at incidence and mortality, and this can be displayed on all 50 states, as you see here is Oklahoma, but we can also do it nationwide. We gain the incidence data from the cancer registry programs that are conducted by state health departments. The mortality data is also attained from state files. The radiation index is obtained from the satellite data from Emory. And then there are 4 other areas that we have the available to get on a dashboard, and that is the percent of developed impervious surfaces, the percent of land covered by forests, the percent of land used for development, and the number of extreme heat days. And these all are variables that we can use in putting together a picture of what may be occurring in your state or even in county levels. Now, I put together the dashboard for Oklahoma because that's where I live, and I just used 2 different things for this. One shows the daily average UV index, and then the other shows, and that's on your left side, I think. And then on your right side is the melanoma rates. Now, what's interesting on this is that where you see high UV doesn't always relate to large numbers of cases. And where we see the large numbers of cases are around what we consider the part of Oklahoma that is woods, lakes, rocks, and hills. Not maybe mountains. We do have mountain ranges here, but I don't consider them really as mountains. I consider them as high hills. And so these lakes are large. They're all man-made lakes. They have a lot of shoreline. And so people do a lot of sun worshiping in this area through fishing, swimming, boating, all the different types of water sports that you see. And so those seem to be the areas with the highest melanoma rates. And so we use this data locally to provide skin cancer prevention and control activities, like at the local level with various different groups in the community. And that's how we share the data from the satellite. Now, the chronic disease directors over time have become quite sophisticated in the data that we use. And so we use a lot of mapping tools to demonstrate the data that we utilize, both like through the cancer registry, incidence data, health behavior data, that type of thing. We do use all types of mapping tools and satellite tools that we have to our availability. I thank you for your time this morning. I showed the dashboard link for you to use, and do I have a moment to be able to show the dashboard or not?
Ginny, I think we're on track. Maybe we should go ahead and show the dashboard. That would be, yeah.
Can I show it?
Yeah, please.
And it did come up. Can you see it?
No, I don't. Maybe you should share switch your sharing screen to the dashboard itself.
Did that come up? The last time I did this, it did not want to come up on the Zoom screen for some reason.
I'll recommend that we go to the next speaker, and then when you stop sharing your screen, it might be easier when you stop and start sharing. So we'll go to the next speaker, and then we'll come back around.
Very good. Thank you. And thank you all for listening.
Okay, thank you. All right, let's go to our next speaker. So our last speaker for this session is Emily Hall from Texas Department of State Health Services. So Emily, you have the stage now.
Hi, everyone. It's great to be here with you today. My name is Emily Hall. I'm a senior research scientist and technical team lead with the Texas Department of State Health Services Advanced Analytics team. And kind of continuing on the dashboard theme, I wanted to talk with you all today a bit about our COVID-19 data dashboards and our overall data dissemination efforts at DSHS, and specifically within the Center for Health Statistics, where my team is located. So I wanted to start just by also orienting you all a little bit to where we are within the organization and explaining a bit about why we are involved with the COVID-19 and how we're involved with the COVID-19 response efforts, because in our area, we typically are not working on infectious disease surveillance topics, but as you all are probably all aware and probably have all experienced, to some degree, many of us who work for public health agencies were drawn into COVID-19 response efforts. So the Center for Health Statistics is essentially the agency's source of data dissemination for the state of Texas. So we really strive to provide timely and accurate health information related to public health in Texas. So CHS is made up of 4 program areas, and these include our Texas Healthcare Information Collection, which is all of our hospital discharge data, as well as vital statistics. And also we have an agency analytics unit, which is where our COVID-19 data dissemination efforts are housed. So I'm going to talk a little bit more specifically about our teams within the agency analytics unit. So first, my team is really focused predominantly on public health research. And so our topic areas span everything from maternal child health, environmental epidemiology, and chronic disease. And we have a specific COVID-19 data dissemination team that was formed in late 2020. So from the beginning of the pandemic, all of us within our unit were involved in COVID-19 data related efforts. And to the extent where we decided we really needed a dedicated team to be formed. And so we essentially started out by building the agency's dashboards for the state of Texas and maintaining the publicly available files that are updated every day. All of that can be found at the link below, and I'll show you some screenshots in just a moment. But starting in September of 2020, we were tasked with essentially coordinating the data strategy for the entire agency. So that involves collating data from a wide variety of groups to inform all of our metrics for the state. So that's everything from hospitalizations to testing data to case counts. And that was quite an effort, as you can probably imagine. And I'm sure that everyone has heard stories of some of the challenges that our public health system has had generally related to just modernization of our data infrastructure and sort of the massive task of collecting information on millions and millions of cases. So this team continues to perform all of these tasks related to COVID-19 data collection, wrangling, cleaning, visualization. And so while we don't, set the specifications for case definitions or surveillance methods, we are sort of at the end of the chain of data collection where we wrangle everything together and try to put it into a package that is easily accessible for the public. Just a screenshot of our website where you can find Excel files that are updated daily that do contain data from overtime related to cases, fatalities, hospitalizations, testing, and some topics related to schools and vulnerable populations. This is a screenshot of our data dashboard, which obviously this is an old screenshot. We have many more cases, unfortunately, here in Texas at this point. And the dashboard was actually recently overhauled due to some changes in surveillance data sources. And so sort of beyond the COVID-19 data wrangling and dissemination efforts, we have a broader goal, which is to really be the source of data dissemination for health topics in Texas. And so we have another team that is dedicated to maintaining our Texas Health Data Portal. Currently, it has over 40 health data visualizations related to a lot of different health outcomes. And we are trying to incorporate more data sources related to exposures, different environmental exposures, risk factors among the population. And so here is just a screenshot of what this dashboard looks like. And we are always really interested in receiving feedback from potential end users related to the data that are presented here. We're currently conducting some user experience testing to try to make this more accessible for a wider audience. It can be kind of challenging sometimes because we want to present the information in a way that could just be easily understood for anybody, but then also would meet the needs potentially of people who are wanting to address research questions with these data. And so here, this is just an example of some data briefs that we've put together to achieve this goal, I guess, of making the data more accessible and easily digestible. And so, yeah, this is always just an area that we're continually upgrading and adding topics, and really do appreciate feedback from end users. So we additionally have a GIS team that has been involved in all of the efforts that I've previously mentioned, including doing some spatial analyses related to COVID-19 data. And they also participate in building and maintaining our data dashboards. And so this is I think, really great resource, because we're able to geocode, we're able to join different data and look at spatial relationships. And we also provide assistance to others of our agency in doing the same. And here's just an example of some of their work. And so that's really the main overview that I wanted to provide you all with today, just to give some background on how COVID-19 data are collected for the state and what our goals are at DSHS related to data dissemination. We ourselves are not specifically looking at impacts of COVID-19 on air quality, but do hope that the data we're collecting and sharing are helpful to others who might be doing similar efforts. So that is really all I have for you all today, although I have a couple extra minutes, so I may go over let me just open up our dashboards really quickly. Yes, so this is just an example. This is our COVID-19 data dashboard. And so, we try to look at trends over time, demographics, and then there's some additional information about the data and how it's collected, because there are many caveats, as you can imagine, to these data, especially the case data. I mean, initially we were collecting those really from local health department websites from across the state. It was a manual process every day. And so lots of considerations when using these data. We tried to be really transparent about all of that in our dashboard. Then this is just our Texas Health data. So we are adding some dashboards related to environmental health, and are always interested in hearing from you all who are experts in things like air quality about how we can best present these data, because that's the other thing that we're really tasked with, is that we want to present the data, but we also want to provide enough information for people to be able to interpret and use the data in a way that aligns with any considerations that should be taken when using them. All right, and that is it for me. So thank you so much for having me here with you all today.
Thank you, Emily. So that concludes the presentation part of our session. So what I'm going to do next is I'll begin with one question while Adeline, maybe you can try to share your dashboard. I thought it would be useful for others to see your dashboard as well. But this question is dashboard related, so this will be relevant here. So this question is to both Adeline and Emily. And it's about how long does it take to develop dashboards that you're showing, and what the process is involved. And I guess particularly the person wants to know, or we all want to know, just, as researchers, how should we interact with organizations like yours in order to contribute and maybe incorporate our data with your platform, especially in a situation such as COVID with, emergency issues. So that's the question. I think you're muted, Emily, if you're trying
I'll
to.
speak to
Oh,
the
okay.
issue working with a national organization. When we worked with CDC and Emory to obtain the data to develop the dashboard, it took about maybe 8 months to put together the dashboard. Now, unfortunately, when we started doing this, many people in the environmental tracking division who actually developed these dashboards were pulled for COVID activities. And so they would maybe be able to work on these dashboards maybe once a week, or maybe not even once a week. So it took probably longer, because they told us originally when we started working on this, it would take about 4 months to develop the dashboard after we had worked with our constituents to determine what we really needed. And so when we did the focus groups, when we did the work groups, that kind of thing, that was an effort of about 3 months. And then they told us it would take about 4 months to do the dashboard. And then they wanted us to alpha test it and beta test it both. And so that was in that 4 months time frame. So it should have really been able to go up live within about 8 months. But we started with the dashboard about 2 months before COVID hit. So I think it was like in January of 2020, with talking with the people in environmental health, and then they talked with the Emory group also. And from that, it took until May of 2021 for Dr. Richards to make it go live and go public. But normally it would have only taken about a year, they thought, because it also had to go through CDC clearances, and going through national clearances take a long time. So, but actually they were all based on what our constituency felt that they needed.
Yeah, and on our end, I think it depends on what topic you're referring to, I guess, because, you know, for the COVID-19 dashboard that had to be done basically overnight, and then there's just been many iterations, and it's constantly being updated, I would say, and there's definitely approval processes that have to happen before each update occurs. And then for our Texas Health Data dashboards, that typically depends on the complexity of the data visualization and how many parameters they're wanting to include, and how many stakeholders need to review and provide feedback. And then, yeah, exactly, the internal and external review processes definitely influence the length of time that takes. Actually, building the dashboard usually doesn't take so long, but there's always, lots of back and forth about, looking at data quality of the data that we receive to make sure that it is correct, and then looking at whether or not we've met the requirements that are set out by the data owner, or the requester, whoever's requested the dashboard. So it's a little difficult to answer in terms of specific amount of time for those. Oh, but in terms of feedback and interacting with researchers, we love it when people just email us and want to have a discussion and or have questions. We're happy to to engage around any of this, and our email is on the website at the link that I provided on the slides.
Can you see the melanoma dashboard?
Yes.
Okay. So you select your state up here. So since Emily was talking about Texas, my next door neighbor, there's Texas. This gives you the melanoma incidence rates in Texas. Death rates. These are over 10-year time frames, because the numbers of melanoma deaths and incidents are not super high And so you have a lot of these gray areas are suppressed because there's not enough numbers to demonstrate. Here is the number of extreme heat days in Texas. So this just gives you an example of what we can use. And then the UV is which we were addressing specifically, shows you the levels of UV. The darker ones are the greatest average or highest level. So easy to do. Even I can manipulate it. Just can't always display it.
Thank you for that. All right, so let's get on to other questions. Let me see what's the next one. Well, so this one's to Randall. And this person wants to know, for the satellite-derived PM2.5, are there any daily files that you have been working on or have planned to share?
Yes, so thank you for that question. And at this time, our focus continues to be on the monthly to annual scale, really driven by the impacts of long-term concentrations on morbidity and mortality. So we're really focusing on producing accurate data at these longer timescales of relevance for assessing chronic effects, rather than focusing on the short-term concentrations for acute studies.
All right, thanks. So let me see. So Jonathan, well, this is Randall again. In the pie chart that you showed, the residential sources has been shown as the largest contributor. And is this a global thing, or it's more related to electricity generation from coal, et cetera, or other reasons?
Sure. So the large pie chart showing the large fraction from residential combustion was at the global scale, and that's driven by burning for largely cooking, also for heating, largely in South Asia, but also other parts of Southeast Asia and parts of West Africa, for example, that lead to PM that expand, or that goes beyond the indoor environment and contributes to degradation of air quality to the outdoor environment. So although there is an indoor component associated with that, those activities, we did not at all assess the indoor component, but rather we just looked at the effects of those activities on the outdoor environment.
Thank you. So let's switch to Gaige. And this question is about your base model simulation and converged with the observed NO2 concentration during the pandemic lockdown. What does that indicate about the factors that may influence NO2 under bias in your base model?
Thanks for the question. There's a couple of things that could be going on. One of those things could have to do with the model's emissions. Many of these models, not just GLCF, use emission inventories that are outdated. These bottom-up emission inventories take a while to construct. So often, if you're trying to run something for, say, 2019 or 2020, you're relying on emission estimates from, maybe 2015 or so. So that could cause some of the bias. Although with that said, I would expect, given decreases in NOx emissions in the UK and in Europe in general, Western Europe in general, it's probably not the cause of the low bias we're seeing for London. Another thing that could be going on has to do with how we measure NO2. Some of these in situ NO2 monitors have known issues with chemical interference from other nitrogen containing species in the atmosphere. So if that's the case, the bias that we might see when comparing a model to observations might not actually be a true bias. It could be a bias in the instrument and the way it measures NO2 in the outdoor environment itself. So all this is to say, I don't know if I can pinpoint exactly the reason that there is this bias and what it might suggest about the model and its inputs, but I think both of those factors could be coming into play, not just for London, but for a variety of urban areas around the world.
Thanks. Let's go over all the questions that we have had so far, and then I have additional questions for all of you. So the final question showing up on this Q&A board from Zach to Randall again. And the question is, what was the spatial resolution of the model used to estimate surface concentration? Could local scale impacts of COVID emissions change to be obscured by your methods? Okay, so that's the question.
Yeah, thank you. That's a good question. And it's something we spent a lot of time thinking about. And so the spatial resolutions of the model were 0.5 degree to 2 by 2.5 degree, depending on the regions. And there is always the likelihood that the inputs into these estimates lead to a coarsening of the information. And there is always a likelihood that there is going to be local scale effects at finer than we observe from satellite or at finer than we model. However, I don't believe that that is a significant issue for the case that we've examined, because if it were, we would have seen that in the observations, and we don't see anomalies in the observations that are distinct or different from the satellite-derived estimates. Nonetheless, resolution is something we, again, spend a lot of time thinking about and are working towards a new high-resolution version of GeoSChem, GCHP, that is conducting or enabling very fine-scale simulations. We have a paper that's submitted on that topic, and hopefully at a later date, we'll be able to speak about that in more detail.
Thanks. So Jenny, I see your question, but I'm going to save that for the last, because I have a very similar question to what you have posted here. So my other question that I have while I was listening to your talk, all of your talk, but I guess particularly the talk from Randall and Gaige, is that you're studying the consequences of COVID-19 lockdown on air quality. And as I'm a public health researcher, epidemiologist, I've always been wondering, what's the health implications of those changes in air quality? And that health implication can be, COVID related or other diseases. So do you have plan, or have you learned from others that have looked at, the health implications of those changes in air quality, and maybe differences, the variability in air quality change across different regions? Is that correlated with different health outcomes?
That's a great question. Gaige, I don't see you unmuted yet, so you should chime in, but let me start, at least with my thoughts. And that, so indeed, there are a lot of questions to answer here. And our first goal is to produce data that people can use for their own purposes to investigate those type of questions. And an intriguing aspect of that might be understanding. So there's always this challenge of disentangling what are the influences of PM on health outcomes versus some other air quality components such as NO2 on health outcomes, or even ozone. And what this offers is then a chance, when there are large changes in NO2, relatively small changes in PM2.5, maybe that can help to tell us about the influence of different components of the air pollution mixture and their effects on health outcomes. Of course, it will be an immense challenge because the healthcare system itself underwent a large shock to that system, both in terms of the intensity of care that was provided and its impact upon some other treatment of issues that, for example, went beyond COVID itself. So it will be a challenge to disentangle, and I'm sure it'll keep us busy for many years.
I don't have much else to add beyond just, yeah, it's a challenge. I think we have enough evidence to say that if there's a decrease in air pollution, there are probably some health benefits incurred, but detecting that signal from the noise, especially when people sought out care and emergency care at hospitals differently, is not something that's particularly easy to do.
Mm-hmm.
Could I possibly comment on that as a healthcare professional? I think that when we look at long-term COVID and the issues around the people that have long COVID and the lung problems and they have and the other organ problems they have, that these air pollution will be, I think, a big factor for them in quality of life and survival, long-term survival.
All right. So now let's discuss about Jenny's question. It's to all the panelists, and it's about how COVID-19 has changed the way you think about your research area. And I guess for the panelists who are from the health departments, I guess it's about how you changed the way you think how our researchers can contribute to your work. So it's really a general question, and hope to hear your input.
Okay, I don't see anyone else unmuting yet, so I guess I'll start, and hopefully others will join in. I guess one reaction is that COVID was immensely surprising in a number of ways, and to me it drives home the importance of making data easily accessible to the community, because there are likely questions that emerge quite suddenly that can be informative and valuable to our community if there are data that are available to answer those questions. So to me, it drives home the importance of making data available without necessarily knowing how those data will be used, but just trying to make high quality data sets as a service to the community.
Yeah, sorry, I had to take a minute to think about this because it is sort of like a deep philosophical question, that I think many of us working in public health have kind of been wrestling with a little bit over the past 2 years. So I would say more than how it's changed how I think about my research, I think that it's really highlighted exactly what you were saying, Randall, just the need for rapidly available data. And then it's really brought to the forefront some of the challenges that we have in public health, in our public health data infrastructure in making that happen. Is fully addressing some of those technological limitations, I guess, so that we're better prepared in the future.
Emily, you expressed it very well.
For me, I think COVID forced me to think a little bit bigger than my own research areas. A lot of the communities that I focused on as being impacted by NO2 pollution and other forms of pollution are the same communities that maybe lack broadband internet access, and maybe the kids there don't have iPads and Chromebooks and laptops to really do distance learning well. And you could keep going on and on with all these issues of justice and equity. So I think it's again made me think a little bit bigger and think about ways that I can work with stakeholders, with other scientists who are researching a lot more topics than just air pollution and air quality to advance environmental justice and equity.
Thank you. And let's see, well, we're close to the 10:15 mark, and I would like to thank all our panelists for their wonderful presentations and all those people who have participated in the Q&A session.